the biggest is Mediclinic, and it's responded to the Competition Commission's Health Market Inquiry, saying the data that they used to develop the findings of the report are outdated and incorrect. So the report highlighted that the healthcare industry is concentrated and offers little options for consumers. And joining me now to talk more about this is Roly Bays, who's Mediclinic healthcare consultant. Roly, many thanks for your time this afternoon. What data do you have that shows that you are not anti-competitive and that you are not inflating prices as the report would suggest?
Okay, well, you sort of raised two issues there, so let me deal with the one that you've just asked me directly, and that is around prices. And what is interesting is the Competition Commission, the HMI, actually in their preliminary reports and in the reports that they published before they actually did the interim report, made very clear that prices were not an issue. In fact, they made the finding that prices were very close to or just above CPI for the entire period that we are looking at. So it's not about price increases, it's about utilization levels. And you'll find that much of the discussion, which was not done by the hospitals per se, but rather by the medical aids and Discovery and a few others led that debate, was around anti-selection, which is a phenomena where you don't have mandatory membership and you allow members freedom of choice to buy into a medical aid when they need it. And so the CMS report that gets published annually shows very clearly how young people at the ages of around about 21, 22, when they come off their parents' medical aid, choose to not buy medical aid until they're a couple of years later on when they really need it, when they're starting to decide to get married, have babies, and all those kind of things. And so for a number of years, this group of people don't contribute to the cross-subsidization model which is needed. Now, there's a very interesting study done by Heather McLeod and another chap, I can't remember his name offhand, about 7 or 8 years ago that showed that if there was mandatory membership, which was one of the requirements of the original PMB system, which was proposed in 1998, was put in place, the average premium of every member in the country would come down by about 20%. So we clearly have anti-selection. And anti-selection then drives utilization levels. Now, I'm not saying there's not problems. I'm not saying there's possibly not fraud. I'm not saying there's possibly not a bit of supply-induced demand here and there. But, I mean, the reality of it is we have a fundamental problem because the system wasn't introduced properly and completely, that we have an adverse or unintended consequence in the system.
Yeah, and I mean, we'll get into some of those details a little bit later in the conversation, but I want to pick your brain on you agreeing with some of the recommendations of the Competition Commission, even though you are saying that some of the data is really not something that can be relied upon. Talk us through that sentiment.
Sure. I mean, I think it's something that we as a group for many years have recognized there's a need for patient satisfaction information to be published to members and quality information to be published. So for a number of years, Mediclinic has published quality information for about the past 10, 15, 20 years, even on our annual financial statements. You'll find that we're publishing quality information. The last 4 or 5 years, we've been publishing an independent, internationally recognized patient satisfaction index where people are asked randomly to evaluate the service and give an indication of what they want. This is what the HMI is now saying is necessary. We've done it for the last umpteen years. The point is that Mediclinic can't just publish its own data. The reality is you need a national system, and this is the statement that the judge made, that the Department of Health hadn't done their job properly because they should have implemented these factors many years ago. They're part of the National Health Act, and they are part of a proper system. So let me give it to you this way. If you run a race and there's a 5-year-old, a 15-year-old, and an 80-year-old, and we all run 100 meters, it's not right to say that the guy that's 80 years old is slow. We should be measuring him against his age group, against his health spectrum that he has to live with. So what we need in the country is a national database where all the quality data is submitted and where you then measure Mediclinic versus the national average, life versus the national average, et cetera, et cetera, et cetera. And not only hospital groups, but at doctor level, et cetera, et cetera. then you can say, I'm measuring like with like. In other words, if we then have data published which says appendectomies between the age of 18 and 27 with no comorbidities, the length of stay should be 2 days or 1 day or 10 days, and Mediclinic is either above that or under that, that would be an indication of whether the quality is good or bad or indifferent.
Really, so my apologies for coming in there. We are running out of time, but I must ask you, you do agree, though, that one of the biggest problems with the industry as a whole in the country is the fact that consumers are suffocating from the high cost and the very little variety for them to choose from?
It's true. Well, they have variety in the sense that there are a number of medical aids they could choose from, and there's a lot of competition in the hospital sector. I think this is one of the reasons why we stated that we thought the information that the HMI published was not adequate. The report is 2014. The actual date today is 2019. In the last 5 years, there's been a dramatic increase, a huge increase in the number of independent hospitals that have grown up. The Day Clinic Association has grown significantly. So there's, in fact, a huge extra choice in terms of facilities that you could choose from, while at the same time the medical aid market is actually maintained or has stabilized at around about 8.5 million people. So, in fact, today people have greater choice. And the reality is for us, for example, is that we would have a hospital in Somerset West, and one of the independents is built literally 2 kilometers away. So people have choice. That's really not an issue. It is an expensive commodity, but it's expensive because of the cost associated with it. And I think it's important for the listeners to understand that for us to build a hospital bed, you need to put down 3 million rand. For us to put a nurse in the general ward, we have to guarantee 7 to 8 hours worth of nursing. Now you can go on the per-cell system and see the state's nursing salaries. And let's not argue whether ours are more or less than theirs. Take the state salary, divide that by 160 hours a month, and you can work out what the hourly rate is for that nurse, and then understand that if you stay in a general ward for a day at about 2,500 rand, you're getting the nurse for 7 or 8 hours, you're getting the room, the bed, and you're getting 3 meals a day. So it's not expensive within the context of the input costs.
But the consumer does feel those costs nonetheless. Really, thank you very much for your time this afternoon.